So we're about 2/3 of the way through the course. Next topic is respiratory. So the gas laws are pretty important if you're doing anesthesia or if you're doing mechanical ventilation. They're pretty interesting to think about in relation to things like flying on an airplane, diving in the ocean, those kinds of things as well. So they do come up more often than you would think. So the first law that we'll think of is Boyles Law. So P1V1 equals P2V2. So pressure times volume will equal pressure times volume in a different setting. So think about someone that's flying in an airplane. The partial pressure of air at sea level is 760 millimeters of mercury. If you go to 8,000 feet, which is what most airlines are actually pressurized to, then the partial pressure actually goes down to, say, 670, 680. That means that the volume of oxygen that you need to offset that amount of pressure is substantially more. This is why when people fly in an airplane, they often feel very, very tired. This is why when people who have COPD or asthma fly in an airplane, if they're having any symptoms at the time, they'll often have worse symptoms just because when you look at the partial pressure, if you're looking at the oxygen, which is, roughly 28%, 28% of 760 is much different than 28% of 680. So it is an important thing to know. The opposite is also the case, because if you're in a scuba diving situation and you go to 33 feet, therefore you now are at 2 atmospheres. 1 atmosphere equals 760 millimeters of mercury. 2 atmospheres, of course, is 1520. That means that if we are giving oxygen, then we can get the partial pressure up to twice as high. So if you're at 28%, if you're at 100 partial pressure at sea level, you can easily get it up to 200, and especially if you start using things like an aviator's mask or whatever, you can get the PO2 up to about 400 at 2 atmospheres. The further down you go, the greater the number of atmospheres and the more oxygen you can get to dissolve into the bloodstream. This is the basic concept of hyperbaric oxygen. So Charles' law basically says the same thing, except it's related to temperature. That means that the volume of oxygen changes. Therefore, if you are in a higher temperature, you get a little bit less partial pressure of oxygen. And you do need to consider. This is why people, when they get hot, have a harder time breathing. The ideal gas law actually talks about a gas constant as well as any number of moles of a substance. This is used to try to figure out the amount of oxygen that someone's receiving at various pressures, at various temperatures. And you can see that we can actually figure out, pressure times volume equals the number of moles of a substance times the gas constant times the temperature. So we can actually use this equation to figure out how much oxygen someone is receiving. Compliance equals change in the volume over the change in pressure. Obviously, if you've got lungs that are not as compliant, they're not going to be able to get as much volume in. Ventilation perfusion mismatch. This is something that we used to do a lot of, a so-called VQ scan. We don't do it very much. You'll sometimes see it done in someone who is highly allergic to CT contrast, because if you have a pulmonary embolus and you really need to know, the normal thing to do is to do a CT, and if you can't do that, VQ scan is an option. But in those people, they sometimes just have atelectasis, but it also can be a sign of a pulmonary embolus. You can compute the alveolar arterial gradient. There's various equations that can be found in Hippocrates and in MD Calc. and you can also figure out, obviously, using imaging. The oxygen dissociation curve is important, especially in critical care. It changes depending on what the environment is. So if you have somebody who is in a higher temperature or has a higher temperature, has decreased pH because they're in acidosis, and increased CO2, which would be consistent with that, it basically allows more of the oxygen to be released from the bloodstream and be released into the tissue. So we decrease the oxygen affinity to the hemoglobin. The opposite occurs in people with alkalosis, decreased carbon dioxide or low body temperature. We don't release as much. Now, with low body temperature, you don't need as much oxygen, but it is something that factors in. Therefore, if you have someone who has a low body temperature, you may want to try to raise that temperature to help them release more oxygen into their tissues. And again, if they have a decreased CO2, sometimes you're going to change their BiPAP settings or change some kind of a setting to help them release more oxygen into their tissues. So Dorothy Kirov is a 60-year-old woman. She's coughing and she has a lot of reddish-brown sputum. She went to the ER and they started her on some Augmentin. Now she's back in your territory and she has a temperature of 103.4. Well, what are the possibilities here? Her chest x-ray does show a left lower lobe infiltrate. The left lung, of course, does only have the two lobes, the lower lobe here and the upper lobe. There is a structure that's sort of analogous to the middle lobe that's sort of located in this area. That's referred to as the lingula, and you can actually have a congestion in the lingula. The thing that I think is very interesting is people will listen, say from the back, and they will listen up here, and they'll say, oh, they've got a left upper lobe, or they've got a middle lobe or whatever. The problem is that with this fissure that goes down just like this, it's really hard to know what lobe it is. So whenever I describe lung sounds, I just say the left upper field or the left lower field. Without a chest x-ray, it's really hard to tell which lobe it's actually in. The right lung, of course, has this middle lobe here, the upper lobe, and the lower lobe. And again, same kind of thing. You listen here. Is that a lower lobe thing? Is that an upper lobe thing? Is it a middle lobe thing? Very difficult to tell. On this chest x-ray, you can see trachea's midline. That's reassuring. We don't see any effusions down here in the gutters. We run the margin of the heart. We see there's a little bit of cloudiness, especially here where it's really hard to tell what's heart and what's lung. This margin's a little bit more defined. We can also see that there is a collection of whiteness here. These are just lymph nodes that are in the perihilar area, but you can see there's no pneumothorax. There does appear to be an infiltrate down here in the left lower lobe. So she has a white count of 24,000, so she has a substantially elevated white count. Her neutrophils are up and her immature granulocytes, which are usually neutrophils, are elevated, which would be consistent with a bacterial infection. She's a non-smoker. How'd she end up with pneumonia? Well, lots of people that are non-smokers end up with pneumonia. It's a bacterial origin. They can be exposed to the bacteria. Smokers, of course, are more at risk and are more likely to get gram-negative origins to their pneumonias. But people end up with pneumococcal pneumonia very frequently that are non-smokers. So there's two major types of pneumonia, the community-acquired and the nosocomial. Nosocomial, of course, is hospital or healthcare required, and often more likely to have weird origin, bacterial. You can have a viral pneumonia. You can have an atypical bacteria, something like mycoplasmal pneumonia or chlamydia pneumoniae. These atypicals are often referred to as walking pneumonia because people are not that sick. They're usually still walking, they're still working, but they'll have a cough for 2 or 3 weeks. And then in most people with bacterial pneumonia, they're like this poor lady. They are usually pretty sick, high temp, and feeling pretty lousy. Can you prevent community acquired pneumonia? There's 2 major vaccines that we're using. One's a conjugate vaccine, and one's a another word that's escaping me right now. It's a polysaccharide vaccine. So the polysaccharide pneumonia vaccine is the so-called Pneumovax, which is the 23. The conjugate vaccines are actually considered to be a little bit stronger. Now, most kids are getting Prevnar PCV13. We usually reserve Pneumovax for older people. When someone turns 65, we're now giving them the Prevnar, and then the Pneumovax usually a year later. It is a little bit strange because if one has a chronic illness, we only give the Pneumovax. I think this is somewhat controversial. Of the 23 things that are in the Pneumovax, 12 of them are in the PCV. The PCV has only one that the Pneumovax doesn't have. But again, the PCV is considered to be a more effective vaccine. So they may change this over the next few years. But as of right now, if you're younger and you have asthma or other chronic illnesses, diabetes, we would give you the Pneumovax, and then we would give you the Prevnar at 65. Flu vaccine is particularly critical to preventing pneumonia. Flu is a virus and often can cause pneumonia itself, but when it knocks the body's immunity down, it's very frequent that the person will develop a bacterial infection as a superinfection. Gram stain comes back gram-positive cocci. That's usually staph or strep, and so her augmentin should provide her good coverage. She has some reactive airway disease. And so what do you do for that? There's IgE inhibitors. They're complicated ones or monoclonal antibodies, but we can actually get a little bit of inhibition using steroids. Mast cells, same thing. There's monoclonal antibodies that specifically block that, but mostly we use steroids. Parasympathetic stimulation will cause bronchoconstriction, right? So sympathetic stimulation causes bronchodilation, parasympathetic would cause bronchoconstriction, and therefore we might want to use a parasympathetic blocker, something like Atrovent, that would help stop that constriction and allow the bronchi to dilate more. There's lots of other things that we can use for asthma. If it's a histamine issue, we can use an antihistamine. If it's a leukotriene issue, we can use a leukotriene blocker. So in late phase asthma, they'll develop more granulocytes and it'll look more bacterial. They'll actually even develop airway mottling if they haven't been treated for many, many years. This is one of the many reasons that we like to get people on an everyday inhaler if they're using their albuterol frequently, because the albuterol doesn't affect these processes. The albuterol will pull it open and help them breathe short term, but it doesn't actually affect the long-term effects of asthma. So allergens can cause asthma, upper respiratory infections can. We used to refer to exercise-induced asthma a lot. We now refer to that as exercise-induced bronchospasm more, although you will sometimes still hear the term exercise-induced asthma. It is a slightly different process. Obviously, tobacco is evil, and aspirin can actually cause an inflammation in the lungs. I have a discussion question on the discussion board, so I'm actually going to let you guys discuss that issue. Hormonal, we do think that female hormones might be influential in asthma. Interestingly, though, more so in relation to the fluctuation of these hormones rather than the hormones themselves. So they may actually cause some changes. And of course, GERD can cause inflammation of those bronchi. You put some acid in there, you're going to get some spasm and some vasoconstriction and some bronchoconstriction. So I know this isn't a pharm course, but just as a little review, albuterol is a short-acting beta agonist. It's going to open up the bronchi. Atrovent is a long-acting muscarinic antagonist, or it blocks that parasympathetic stimulation. Pulmicort is a steroid. It'll decrease the inflammation. Singulair is a leukotriene inhibitor, which will decrease inflammation as well. If you look at the little picture on the Flonase package when you go to the grocery store, there's 6 different mechanisms: histamine, leukotrienes, interleukins, and this blocks one of them. Intol and Xolair are actually mast cell stabilizers. Intol is not available in the United States right now, other than as a nasal inhaler. Nasocrom is basically the same thing. But Xolair is a monoclonal antibody that some of the pulmonologists are using. It's very expensive, so primary care tends not to use it. So I'm actually going to post some slides from the American Thoracic Society as well. They are pretty old. They really do delineate the respiratory viruses that are involved. Most of these are pretty common. The big issue that they're trying to emphasize to you is that most respiratory infections are viral. But it is interesting when you look at the actual use of antibiotics. These slides are from almost 15 years ago. The use of antibiotics really hasn't changed much. I think we have to ask ourselves why that is. My own personal opinion is that everybody's very afraid of a bacterial superinfection causing major issues, and they would rather make an error of commission than omission. But many patients, if you do explain the potential risks and benefits, will opt to hold off on antibiotics for several days. So Mason is a 35-year-old guy. He's been traveling in Thailand, or he did travel in Thailand 8 months ago. And now he's coughing and he's got bloody sputum. Now, when someone has been to an area where tuberculosis is endemic, we become very concerned. One way to diagnose TB is to do sputums for AFB, which they did do, and his were positive. So now he's been placed in respiratory isolation with a negative pressure room, and he's been put on 4-drug treatment. Generally, tuberculosis requires 3 drugs, and sometimes the more resistant versions require 4 drugs. There's some extremely resistant strains in North Korea right now that I'm hoping never come this way. As we noted, his sputums for AFB. So Mycobacterium tuberculosis is an acid-fast bacillus. There's not a crazy large number of AFB. And so when one has the symptoms consistent with TB, especially with a chest x-ray with a little bit of a almost cavitary lesion, 2 positive sputums for AFB, we're going to make a presumptive diagnosis of tuberculosis. We are not sure he has TB. The gold standard is actually doing a culture for TB. That takes about 6 weeks. It's not that easy to grow out. And we usually, once we make a presumptive diagnosis, we'll refer someone to an infectious disease specialist or a tuberculosis clinic, but they'll follow up in regards to the final diagnosis. Don't forget, and especially since he's been to Thailand, there's a lot of sexual tourism that happens in Thailand, and there is more concern about AIDS exposure, and of course people with AIDS are more likely to get tuberculosis, so obviously he probably should have AIDS testing as well. All right, Jim Phillips. So Mr. Tongue was the sore throat that we talked about earlier in the semester, and Jimmy has a sore throat now. His rapid strep is positive. We make a presumptive diagnosis of strep on the basis of that, just because the potential benefits outweigh the risks. There's some people that are false positives. Sure, there are. There are some people that are carriers. There's some people that just the test is bad. But we worry about strep because of the possibility of rheumatic heart disease and because of glomerulonephritis. And it was a great discussion on the discussion board about glomerulonephritis. And I will encourage you to think about the blood tests that we can do to see if someone's had a strep infection in the past 4 to 6 weeks or so. Agnes Karatsanos, 57-year-old woman. She's got COPD. We diagnosed it 15 years ago. She just couldn't quit smoking. We tried Chantix. We tried bupropion. There are secondary approved drugs, including nortriptyline and clonidine. None of these were effective for her. 2.5 packs for 40 years. That's at least 90 pack years. Cold turkey has about a 2% success rate at 6 months to a year. Nicotine patch has about 15 to 20. Bupropion is 35 to 40, and Chantix is probably 45 to 50. So none of them are fantastic, but we definitely do have some options to help people stop smoking, which we didn't have a number of years ago. COPD is really consists of 2 different conditions, chronic bronchitis and emphysema. There are people that really do have a presentation of one more than the other. Women tend to have more emphysematous presentation if they're not coughing up a lot of sputum, and they do have substantially abnormal PFTs. We may think that it's more of an emphysema element. On the other hand, if you're coughing up a lot of stuff, it is more likely to be chronic bronchitis. She's been hospitalized every 4 to 5 months with COPD. She's got a cough. She's short of breath. She's only satting at 86%. Pulse is actually a little fast at 98%. 98, even though she is not technically tachycardic. She is a little bit tachypneic at 30 breaths per minute. She has no crackles or wheezes, but her lung sounds are extremely distant. She's got 2+ edema in her extremities. What's that mean? Well, sometimes people with COPD have long-term backup into that right ventricle and will develop right-sided heart failure. The term that we use if it's related to respiratory issues is cor pulmonale. If someone has cor pulmonale, they'll obviously have heart failure, and that's something that we need to be aware of. She has slightly distended neck veins, which also would support that. We make a big discrimination between right and left heart failure academically, but in practicality, once you've had it for any period of time, it's going to affect the other side as well. So she might have pulmonary hypertension. How do you tell if she has pulmonary hypertension? Usually that's diagnosed with an echo in an outpatient setting, but obviously if she's in the ICU, they'll do wedge pressures and all those fancy things that I don't fully understand. The normal mean arterial pressure in the lungs is about 15. In the periphery, it's about 90. And if she has primary pulmonary hypertension, obviously she's going to have issues usually of diastolic heart failure as well. PFTs or FEV1 is down. That's usually most consistent with asthma. Her FEF 2575 is down. That's more consistent with COPD. The FEV1 to FVC ratio is usually below 80 consistently in people with COPD. And I think diagnostically it has to be below 70 and not be responsive to bronchodilators. Alpha-1 antitrypsin is a condition that is a genetic condition which happens especially in more in women than in men, but if you have somebody that has very early onset COPD, you may want to test them for alpha-1. It's free now. Various companies that make the alpha-1 will provide it for free because if someone is diagnosed with alpha-1, they will require this medicine for life, and it's about $100,000 a year. We often don't start it until they're fairly symptomatic because of that cost, but most people with it will eventually need it. The Genotype has a couple of different variations. MM is the all clear. ZZ is the disease, but there are people that are MS and some other variations in between. Why is she on asthma court? Why did we put COPD patients on steroids? Well, we used to say it was just for comfort and quality of life. We're now thinking that it probably does affect the disease more. And the usual standard is to put people on anticholinergics, also known as LAMAs, long-acting muscarinic antagonists, a long-acting beta agonist, and steroids. So she is on the steroid. She's also on this LAMA. She's on this LABA. She gets albuterol nebs in between. She's on daily Premarin. We noted the hormonal issues for asthma, but she's going to be on a stable dose, so it's unlikely that that'll affect it. And echinacea is a herbal medicine, which probably should not have major implications. If you find any major implications, please post on the discussion board so I can learn something. So in the hospital, we're going to put her on Solumedrol, which is a steroid. It decreases the inflammation. People with exacerbation of COPD are often put on courses of prednisone. We no longer need to taper prednisone if someone's not on it for at least 3 weeks. The HPA, the hypothalamic pituitary adrenal axis, used to be of concern because we thought that if you didn't taper that people had suppression of that axis and would no longer start producing their own corticosteroids. We now know that that really only occurs when somebody's been on steroids for 3 weeks or more. She's also on antibiotics just because the percentage of people with an acute exacerbation of COPD, even though probably 50% of them are predominantly viral, 50% of them are bacterial. So we usually do cover that basis. She's going to continue her inhalers, probably with the exception of her steroid inhaler, although if she's only on the other medicine for a few days, there's no reason why she can't stay on both. And she's getting albuterol nebs. Now, there are short-acting nebs that have both a short-acting beta agonist and a short-acting muscarinic antagonist. That is called duo neb. So steroids, how will they help? They'll decrease inflammation. Side effects are the usual, buffalo hump and retaining fluid, and sometimes they get grumpy and sometimes they want to eat a lot. And we already talked about tapering. Admission ABGs. So the normal pH is between 7.35 and 7.45, so very mildly acidotic. The next thing that I look at is the PCO2. That should be between 35 and 45. This is normal, and then the base excess is normal. So this is a very mild, probably respiratory acidosis, but it's actually hard to tell. After being in the hospital for 8 hours, her SAT drops to 82%. What do we do? Well, a well-meaning nurse decides that she's not really feeling any different. Her vital signs feel fine. Let's put up her oxygen. Let's increase it to 5 liters. Her SATs actually go up to 91%. Yay! Good thing. The problem is 4 hours later, her SATs are now down to 86%. And when we do gases, we call the nurse practitioner that's on call. This was actually a case that I had when I was at Mercy. And now, in fact, what's happened, her pH has gone down. She's more acidotic. And what has happened to her PCO2? It's gone up. This woman obviously had a hypoxic drive. She only breathed faster when her oxygen went down. And so what happened was by giving her extra oxygen, we slowed her respiratory rate down. By slowing her respiratory rate down, she retained a little bit of more carbon dioxide. By retaining a little bit more carbon dioxide plus water equals H2CO3, which is carbonic acid. And so her pH goes down and she becomes acidotic. Her base excess has gone up a little bit. Her body's trying to compensate for that. And basically the other side of that equation is H2CO3 also equals H plus HCO3. So those are free hydrogen ions, that H plus, and the HCO3 is bicarb. So the body is actually trying to compensate. So she's actually started on BiPAP. Otherwise, she might have to be intubated. After a couple of days, she's now got a bit of an expiratory wheeze. Why were her lungs sound so quiet before? She was very tight. And unfortunately, sometimes when asthmatics or COPD patients are the sickest, they will have little or no breath sounds. COPD patients are notorious for having distant breath sounds anyways because of that big barrel chest. But once they actually start to have less inflammation and their bronchi open up a little bit, they'll get a little bit of a wheeze, they'll get some coarse crackles. I never use the terms rales or rhonchi. I'm a crackles guy. And she feels better, her SATs are up. One of the things that can be used to teach to COPD patients is that if you have them do per-sleep breathing, it'll actually keep that positive pressure high, and it'll prevent that airway collapse so that they can breathe out their carbon dioxide more naturally. So with acidosis and alkalosis, you can be metabolic acidosis, metabolic alkalosis, respiratory acidosis, or respiratory alkalosis. So this is pH is 7.31. So that's acidosis. PCO2 is elevated. That's respiratory acidosis. The pH is elevated. That's alkalosis. The PCO2 is normal. So this is therefore metabolic acidosis, alkalosis, I'm sorry. And you can see that the base excess is 4. This is acidosis. The PCO2 is normal and the base excess is elevated, is decreased, I'm sorry. This is metabolic acidosis. And this is pH of 7.35 to 4.5, so therefore this is elevated, therefore it's alkalosis. The PCO2 is decreased, so therefore this is respiratory alkalosis. This is a patient that's hyperventilating usually. And that consumes the basics of respiratory. There'll be some other talks as well, obviously, and we'll go from there and discuss on the discussion board. Thanks.